Hello. Actually, just to clear up a confusion, my legal name is Colette Fanning, but Pavadarani is the name I go by. It's a Buddhist name. So I'm going to talk a little bit about our next program area, so the second program area for Green Tara. So to put this in context, Green Tara from the beginning has been interested in evidence-based programming. So not just going into an area and running a program, but can we actually test a theory in a context? So the intention was always to take the original program from Farping and take it to another area. In this case, we took it to an area in the Terai in Nawalparasi along the border of India. So same essential model, same essential approach in 2 BDCs. So the area that we were moving into was a very different area. When we first went into the area and looked at the baseline, in the target BDCs and surrounding BDCs, only a third of the women in these areas were having birth with a skilled birth attendant present. There was a very relatively low uptake of antenatal and postnatal care. So we could see that relative to the picture nationally in Nepal, this area was really not at the level that we would expect. So whilst Nepal has made great strides in maternal care, what we see is that there's some difference in social, in terms of women who are disadvantaged due to socioeconomic status or ethnic status. So in this area we're seeing some real, we've listed some of those very different problem sets. So the program was implemented in 2012. By 2013 we had the program up and running. Same essential theory of change that we're working with. One of the things that we do in Green Tara is we do regular reviews. This is part of making sure that the theory, the actual theory that we're going in with, is working in that social context. So what we did is we took some quantitative data from the target BDCs, essentially looking at the same indicators: antenatal, postnatal care, birth spacing, etc. We also did qualitative data. What we were interested in is systems level factors that may be impacting on our program. Actually, what we could see at that time was the program wasn't doing as well as we'd expected. What we found was, the main finding was that there was really limited access in those areas along the border of India to actually a place for women to give birth. There were about 10 kilometers from the nearest birthing facility. So we could see that that was something we had to address. So that led to a decision on the part of Green Tara to support birthing centres. So we began a new intervention. We partnered with the local BDC to implement a birthing centre. So we provided initial startup costs. The proof of concept, the question we were interested in at this point was, does adding health promotion activities increase uptake and utilization of birthing centre services? We looked at, again, we looked at national data, we looked at local data. Nawalparasi at that time had something like 20 birthing centres, many of which were not really seeing women using the birthing centre. So we could see that there was, again, a problem with, in terms of demand and supply, whilst the supply was there, the demand was not happening. So really the health promotion, where we're targeting is on the demand side of healthcare. So as well as establishing a birthing centre with health promotion activities, we also established, you could say, a control birthing centre close by, very similar population, very similar data that we were seeing. So that just gives you a picture. Nashahi, which was opened a little bit later, January 2016, Tulokharatawa in April 2015. So the only difference, really, the main difference is that in the Tulokharatawa, the intervention birthing centre, we have our health promotion activities. So this consists here, we slightly changed it, again, adjusting to the local situation. Monthly mothers groups continued, but now we introduced a focus on mother-in-laws, because one of the things we were seeing in the national data and the local data was, one barrier to access is the fact that the families make the decision for the women. So to really talk to the mother-in-laws about the benefits of using the birthing centre, continued to outreach to the most vulnerable, the women that typically do not access these services. So, really, again, we're looking at the theory of change, the basic theory of change is this is not only a health issue, this is also a social and empowerment issue, especially in these areas where we're working. So we're really trying to affect all these different aspects of healthcare uptake and maternal services. So this is what we've seen in a year. So right now we don't have the outcome data looking at antenatal, postnatal care, etc. We're going to start to collect that soon. But what we do have is just in 1 year we have a picture of the difference between these two birthing centres. So the one birthing centre in Nishahi that has the female community health volunteers who are outreaching to women. We just visited Nishahi. They have a very good A&M, really empowered woman. So a good birthing centre. Meanwhile, in Tulakaratoa, what we have is we have a community health promoter who is running the groups, outreaching to the women. So you can see from the data, the green line at the bottom, the two lines at the bottom, the green and the purple, represent women who are coming to the birthing centre who are being referred to hospitals due to some birth complication. The top two lines, the blue line and the red line, show the numbers of women who are giving birth at the birthing centre. So you can see that we're seeing significantly more births at the Tulakaratoa birthing centre than the Nishahi, and what we're hearing in Tulakaratoa is they're seeing a gradual increase. They expect to continue to see the births increasing. So I just wouldn't want to finish without saying, we're looking at data here, but what's the point of what we're doing? This is not really about data. So I just want to briefly say, I first went to Nawalparasi almost 4 years ago when the program was being implemented. I remember going to groups and I was very interested in, this issue of maternal and neonatal mortality. So I was just asking women, how many of you have lost babies? And I have to say I was shocked. I was shocked at the number of women that would raise their hands. Maybe a quarter of the women in these groups who had lost a child in birth. This is one story of one woman in Tulakaratoa. So this is what she said: I wouldn't have been able to bear the loss of another child. She had her first child at 16. Very typical in these areas. That baby survived. A year later, because she had no access, she had that baby at home, no access to any kind of antenatal care, postnatal care. Second baby a year later, again at home with no antenatal, postnatal care. She had a neighbour helping. There was some complications. They put her on a cart to take her to the hospital. She gave birth on the cart on the way to the hospital. They brought her home. That baby, her second baby, died 2 days later. Due to complications in that birth, she then couldn't give birth for another 5 years. 5 years later, she gave birth again at home with no antenatal or postnatal care. As a result of that birth, she now has a prolapsed uterus. This is a woman who's still only 25 years of age. She got pregnant for the third time, and her neighbour told her, and this is how our projects work, her neighbour told her, oh, you should come to one of the groups. And her family would not allow it, so the community health promoters went to the home, they talked to the family, she joined a group, she gave birth, she had all her antenatal and postnatal care, she gave birth to her third child, this is her with her 3 children, at the birthing centre. So we have to remember that this is not about data, this is about real people and saving lives in these communities. So in conclusion, I think the point has been made that we know that whilst the birthing centres are a wonderful initiative, the demand side is a problem, the underutilisation of birthing centres. Interestingly, just having one community health promoter stationed at a birthing centre doing outreach, social mobilisation in the community makes a difference. This can save lives, very simple intervention.